soft and red is hard. So more the hard areas, greater the score will be. Now coming to the results, so we had 35 patients who had a mean age of 37.37 years and a mean duration of 4.72 years. So comparing cases with disease controls with Sika symptoms, without Sika symptoms and healthy controls, we found that the Hoseva score and the elastography scores did differentiate well between disease controls and cases. The Omerac score did not perform as well in differentiating cases and disease controls with Sika symptoms. Now, correlating the scores with ESSDI and ESSPRI, we found that the Hoseva score had a very good correlation with both the ESSDI and ESSPRI. Elastography had a moderate correlation between ESSDI and a poor correlation with ESSPRI. And but even if you took the hypoechoic section of the Hoseva score, there was still a very good correlation between both ESSDI and ESSPRI. We did a multivariable linear regression and found that the Hoseva, Omerac and elastography scores did have some correlation with the ESSDI and elastography also had a association with the duration of disease. We also did a logistic regression, and those patients who had a high Hoseva score, Omerac score or elastography score had a high odds ratio of having a moderate to high disease activity, and they had even a high elastography score had a high risk ratio of having a duration more than 5 years. Now we also compared whether there was any difference if you did just the parotids, just the submandibular, the right-sided glands or the left-sided glands, and we found that this was almost comparable. And we also tried to differentiate whether these scores differentiated between the high disease activity, moderate disease activity and low disease activity scores, and we found that the Hoseva score was best in these in differentiating high, moderate and low disease activity. The Omerac score did not differentiate between high and moderate disease activities that well, and the elastography also had problems in differentiating between high, moderate and low disease activity. So in conclusions, both ultrasound and elastographic scores were higher in cases than controls, and both Hoseva and elastography scores were able to differentiate patients with primary Sjogren's and other autoimmune rheumatic diseases with Sika symptoms. The Hoseva score had a very strong correlation with disease activity and was able to differentiate between high, moderate and low disease activity, ESSDI and ESSPRI. The elastography scores correlated with the disease activity and duration of disease, but were not as strong as the ultrasound scores. The Omerac and the elastography scores could not differentiate between high, moderate and low disease activity that well. The hypoechoic area domain of the Hoseva score also correlated very strongly with disease activity and might be a simpler way to measure disease activity. There was a near complete correlation of USG scores with unilateral parotid and submandibular scores. The USG scores had significant association with ESSDI and ESSPRI in multivariable linear regression, while elastography had significant association with ESSDI and disease duration. A high USG score had a high likelihood of suggesting a high disease activity, and similarly, a high elastography had a high likelihood of high disease activity and long disease duration. I end my presentation.
Thank you, and over to the judges.
Very well. So, how could you use this in surveying the patients over time? Can you evaluate the therapy using this?
Yes, sir. So, as I talked about, there are two scores that the ultrasound, they use the Hoseva score predominantly, and they see the change in Hoseva score in deciding the response to therapy. So, if your score has reduced, I think by more than 2 points, it is a positive point for response to therapy. So, this was a cross-sectional study, so we didn't evaluate whether it changed over time, but people have proposed the similar findings in other studies.
So, when you make the diagnosis of Sjogren, can this technique in some way replace the biopsy?
There have been suggestions to it. There have been studies who have tried to replace, so they have not replaced the minor salivary gland biopsy with USG, but the minor criteria in the ACI-EULA criteria have been replaced, and they found that the sensitivity and the specificity of the diagnostic, the classification criteria remain the same. If you replace USG with the Shermer's score or the other scores, not for the major two, not for the ROLA positivity or the salivary gland biopsy. They've even suggested a flowchart that if there is a patient who is having suspected Sjogren's and you find a grossly abnormal ultrasound of the salivary glands, and if you just even have ROLA positivity, you might diagnose Sjogren's much easier.
Who performed these ultrasounds? And
I performed the ultrasound.
what was your training curve like? training? How did you train yourself?
Yeah, so I was first trained to see at least 50 ultrasound by a radiologist, and then we shifted to.
So when you chose your controls as within the group,
Yeah.
Healthy controls.
Yeah.
How about patients with salivary symptoms, dry mouth due to non-jugglers?
Yeah, now we had 3 sets of controls. One was patients with autoimmune diseases and sickle symptoms. One was patients with autoimmune disease without sickle symptoms, and one was healthy controls. So we had taken 3 sets, and the Hocevar was able to differentiate best between all 3.
Here your title says primary jugglers, but you have included patients with AIRD with dry mouth.
And those were not in the primary analysis. They were taken in the controls to differentiate whether these scores were able to differentiate between primary and secondary also.
One quick question. Did you think of a lymphoma in any of these cases where the cutoff score was very high? And did you do a biopsy?
So what we ideally did was, these were mostly freshly diagnosed patients. We did a USG and we did confirm it with biopsy. We didn't find lymphoma in any of these patients per se.
Well, thank you very much, Dr. Kunal, for your presentation.
Elastography is done by...
So by us only, yes.
So what do you have elastography for the...
So there are
the same which they use
for the liver. So there are actually 2 types of elastography that is done. One is the real-time, this is a qualitative elastography that we did. The liver one is a quantitative one. You get a value for it. So they have also done studies and proven that this point, any patients who have something 6.5 kilopascals se upar, if you have the value, it is more suggestive of shock.
Thank you, Dr. Kunal. We move on to the next presentation. This is on cognitive dysfunction in lupus, a cross-sectional study from a tertiary care center in southern India. Dr. Ramya Kodari, please.
Good morning, one and all. Firstly, I would like to thank IRA for giving me this opportunity to present my work on this platform with title Cognitive Dysfunction in Lupus, which is a cross-sectional study. We all know that neuropsychiatric manifestations account about 2/3 of patients in lupus. Initially, it was only seizures and psychosis which was included in the criteria, but later the recent the syndromes which were described in lupus had included cognitive dysfunction as one separate syndrome. The prevalence varies between 17 to 60%, whereas the severe cognitive dysfunction, that is dementia, is seen in only 3 to 5% of patients. Patients were otherwise also, the patients with lupus are found to be 2.8 times likely to have more cognitive impairment because of the underlying pathophysiology mechanisms when compared to the healthy individuals of same age group. Actually, the major issue behind this was there are no validated diagnostic biomarkers to diagnose cognitive dysfunction, because of which there are actually very few studies and there is no Indian data which is available so far. And the gold standard tests were the battery tests. The major issue with these battery tests was they were very time consuming, which is requiring minimum of 4 hours to at least 1 hour required, and also it will be done by a trained personnel or a psychologist. And they are also very costly to do. There are various questionnaires which are available to screen cognitive dysfunction, but however very few were validated, among which MMSE and MOCA are among them. Montreal Cognitive Assessment was one among them. The problem with MMSE was it screens for dementia, where we tend to miss out mild cognitive impairment patients. So because of which Montreal Cognitive Assessment is designed to screen out mild cognitive impairment patients. Using a cutoff of 26, the sensitivity was found to be 83% with specificity being 73. It is a very simple questionnaire and it is validated in all 36 languages, and it requires only 5 to 10 minutes to administer. The main objectives of my study was to look at the prevalence of cognitive dysfunction in our cohort and also to look for the determinant factors associated with cognitive dysfunction. We also had assessed anxiety and depression, and we were also interested to know about the association with dose and duration of steroids, and if there is any association with APLA antibodies with cognitive dysfunction. Inclusion criteria includes patients fulfilling SLIC 2012 criteria and patients with juvenile lupus and who had other etiologies with primary cognitive diseases, and patients with acute state of confusion were excluded from the study. Study was conducted over 1 year, that is from March 2021 till July 2022. 205 patients were screened, out of which 160 patients were included in the analysis. All the patients were administered MOCA questionnaire. PHQ-9 questionnaire was used for depression, and CAT-7 questionnaire was used for anxiety. And based on MOCA questionnaire cutoff values, considering 26 and above, we had divided the population into two groups, that is presence or absence of cognitive dysfunction. We also had adjusted the scores by adding 1 mark to the patients with less than 12 years of education. The prevalence of cognitive dysfunction in our cohort was 54%, and prevalence of anxiety was 24%, and the prevalence of depression was 18%. The mean age was 28 years. Predominantly, our population had middle to upper class of group. About 50% of patients had more than 12 years of education. Considering the association with cognitive dysfunction, age, socioeconomic status, and less education was found to have significant association. None of the autoantibodies nor the disease activity which was measured by SLEDAI had shown any significant association. Both anxiety and depression were found to have significant association with cognitive dysfunction. We also had conducted multivariate analysis which had shown that increase in the age, lower to middle socioeconomic status, and lower education of less than 12 years did show higher odds to develop cognitive dysfunction, whereas anxiety and depression did not show any effect. Coming to the individual domains, most common domain involved was visuospatial, followed by attention, followed by visuospatial and delayed recall. We can also see significant involvement of the similar domains in the patients who were not screened to have cognitive dysfunction, which gives us an idea that cognitive dysfunction do occur insidiously in the patients with lupus. When we looked at the other studies, a similar study was done in Malaysia, which had shown 35% of prevalence, and they also had looked at, studied the outcomes of lower, found that the male gender and lower education were associated with Montreal cognitive, cognitive dysfunction. There are very few studies who had actually looked at the longitudinally they had looked at the cognitive dysfunction, where they had noted that there was actually improvement from the baseline over year. Like one study had looked in 5 years and the other study had looked at 10 years. They had demonstrated improvement in the cognitive dysfunction. The major limitations of my study was it was a cross-sectional study. It would have been better if I had used the controls also to explain my findings better. And MOCA questionnaire is just a screening tool. I could not use gold standard test, that is ACR battery test, and the severity of cognitive dysfunction was not able to be assessed because it screens only for mild cognitive impairment. We could not assess the severity of the cognitive dysfunction, and there is a need for long-term prospective observational studies. To conclude, about half of our population had cognitive dysfunction. Increase in age, lower socioeconomic status, and education had lower education had higher impact to develop cognitive dysfunction in lupus. Disease parameters like duration or steroid dose nor the A+ status had shown any significant association with cognitive dysfunction. Thank you.
Thank you. Over to the judges, please.
Yes. Could you tell us how you prepared the patients for the questionnaire? Because with cognitive tests, it's important that you spend time.
Yes, ma'am. Yes, ma'am. So we had taken the patients who were attending only to the OPD, and there was a room which was dedicated to assess my test at that point of time. First, after they finished their consultation, I had taken a consent with them and I had explained regarding the whole process which I was doing it, and I had also told them that we have to administer the questionnaire. And also the language, ma'am. Whatever language they were talking, my mother tongue language related questionnaire was used to administer the questionnaire.
Are these translated versions?
Yes, ma'am. They are all validated and translated in all the languages.
So you said you used most of the questionnaires were binary, time, delayed recall, present or not. But time to recall, like, is there a graded scoring system also?
No, ma'am, it was not there. It is just the scores were mentioned as whether it is, for each domain.
The time you took?
Ma'am, for each patient I had...
Say time to recall, delayed, yes or no. So within what time, if they give you an answer?
Ma'am, we have to take 5, that time was not there, ma'am. There is nothing like, so the previous, whatever words I will be giving immediately in this, after completing the visuospatial domain. Meanwhile, I will be administering the other, checking for the other domains also. After that, I will be asking for the delayed recall, which I had already given some words previously itself. So I had taken, so for administering MOCA questionnaire, I had taken a course for it, ma'am. So I was also provided a certificate because I had taken a course for it. So they didn't mention anything like it has to require minimum of this much of amount of time. Later of that only we have to administer delayed recall.
So you mentioned that all these questionnaires demand quite a lot of resources and time from you and from the cloud providers. Is there any more possibility to digitalize and make this digital? Because there are a number of digital tools for evaluation of cognitive
I didn't get
disorders.
the question.
What are the possibilities to make these tools digital? Digital.
Computerized.
So I don't think it will be easy to do MOCA. Regarding MOCA questionnaire, I didn't get the.
Yeah, take the questionnaire, be digitalized and ask you the questions.
Oh no, okay. I'm not sure, sir. I don't think it can be done in our setting where the education levels will be little lesser to the patients. So I.
And are you not planning to use this instrument longitudinally? Are you planning to use
Yes, sir. Even we are also planning to look at the prevalence after some time and period and really see if it is being reflected like how it was already studied in other longitudinal studies.
Thank you. Just one quick one. Since they were from a low socioeconomic status, did you do things like vitamin D and did you look at the nutritional levels of these patients? For vitamin D, low levels of vitamin D are known to sort of mimic, cognitive dysfunction or
No,
worse.
sir. I actually didn't think in that.
Thank you. We move on to the next presentation. That's on childhood vasculitis. Chandigarh, 29 years experience. Dr. Suprit Basu.
Good morning. Today I will be presenting my paper on childhood vasculitis. So, it's a multi-system autoimmune disorder involving blood vessels of varying sizes. It can be primary or secondary. The annual incidence of primary vasculitis is around 23 per 100,000 children, and around 7% of all cases who present in pediatric rheumatology clinics is of primary vasculitis. And it's not changing. The prevalence of different types of vasculitis varies from different ethnicities and populations. So our aim was to report the pattern of primary childhood vasculitis from a tertiary care center in northern India over the last 3 decades. It was an institution-based review of records of patients registered in pediatric rheumatology clinic over the last 30 years, and we excluded the undifferentiated vasculitis and secondary vasculitis. Demographic details, seasonal trends and clinical features were analyzed. These are the 2 main classifications that were used for primary childhood vasculitis classification criteria. Among the total 8,070 patients that was registered in our pediatric rheumatology clinic, around 20% of cases comprised of primary vasculitis, and the most common primary vasculitis was Kawasaki disease, which comprised of around 69% of cases, followed by IgA vasculitis of henoxanal purpura, which comprised of 25% of cases. The only large vessel vasculitis we encountered was Takayasu arteritis, and the most common type was type 4 followed by type 3. Among the medium vessel vasculitis, childhood polyarteritis nodosa accounts for around 2% of cases, and among the childhood polyarteritis nodosa, we had 15% of cases of monogenic vasculitis, that is deficiency of adenosine deaminase 2. These are some representative images of the skin lesions, the CT imaging of childhood polyarteritis nodosa. We had 6 patients of granulomatosis with polyangiitis and 10 patients of microscopic polyangiitis. We did not encounter any case of eosinophilic granulomatosis with polyangiitis in our cohort. Among the most common vasculitis, the Kawasaki disease, we found around 15% of cases of infants and 8% of cases of children more than 10 years who are the high risk group. We had complications like KT shock syndrome in 3% and macrophage activation syndrome in 1.3% of cases. The most dreaded abnormality, that is the coronary artery abnormalities, were found in around 20% of cases. These are the representative images of echocardiography and CT angio changes in Kawasaki disease. Among the HSP or IgA vasculitis, 20% of cases developed the graded complication of HSP nephritis in our cohort. When we compared the sex distribution, we found that Kawasaki disease, henox-Solon purpura, and childhood polyarteritis nodosa had a mean preponderance. The median age of onset of Takayasu arteritis and Ankylosing vasculitis was in the older age of onset, whereas Kawasaki disease and henox-Solon purpura had a younger age of onset. We compared the seasonal variations in Kawasaki disease and henox-Solon purpura, and we found that Kawasaki disease has a bimodal peak in the May and October, whereas HSP showed peak in November. And in our cohort, after 2004, Kawasaki disease has been gradually increasing as the most common vasculitis. Prior to that, HSP was the most common. We are the only center in India to have an incidence data of vasculitis, and we calculated incidence data of Kawasaki disease at Chandigarh, and it is 10.6, which is comparable to the European countries. And these are some of the publications that has been published from our center, which shows the Kawasaki disease incidence is increasing in India. When we compare the distribution of primary childhood vasculitis around the globe, our data is almost similar to the Eastern world, but in Western world still the HSP is the most common vasculitis. So what we conclude is that Kawasaki disease is the most common vasculitis, childhood vasculitis, most common primary childhood vasculitis, and it is commoner than all the 4 other vasculitis compared totally. It was the largest single center pediatric vasculitis data from India, and it is the only center in India to report epidemiological data on Kawasaki disease. And we have screened for monogenic vasculitis, and we changes the treatment guidelines. And there are some limitations. It was the institution-based records, so there is a chance of referral bias. Uncomplicated and milder cases may not have been referred, and the single center data for generation of this result in Indian population, we need multi-centric data from all regions of India. To conclude, primary pediatric vasculitis accounts for around 20% of pediatric rheumatological cases. Kawasaki disease is the most common childhood vasculitis, followed by henox-Solon purpura in this part of the world, and the incidence of Kawasaki disease is increasing. Both Kawasaki disease and henox-Solon purpura have seasonal variations. Kawasaki disease and HSP have a younger age of onset, whereas Takayasu arteritis and Ankylosing vasculitis are seen in older children. And we report increasing incidence of monogenic vasculitis among our cohort. Thank you.
Thank you. Questions?
Mike, please.
What are the possible biases in saying that KD is increasing in incidence in your center?
Most commonly this is HSP vasculitis, HSP or henox-Solon purpura or IgA vasculitis is the most common vasculitis that has been reported.
No, I'm talking about your results which say that KD is increasing.
Yes, ma'am. The confounding factors will be that the milder cases of HSP that is not been referred because that is only the complaint is palpable purpura and some abdominal pain.
So that's one.
That is the one. And the second is that our center is the tertiary care center with tertiary care center for Kawasaki disease also means there is a referral bias, ma'am, because as our HOD sir, Professor Sujit Singh,
so there's a
referral bias is there, ma'am.
Yes.
Another point is that we have to compare either HSP or Kawasaki disease. Out of this one, the more the pediatricians are diagnosing HSP in the primary or secondary center, ma'am, so chance of referral is less.
So this is a very impressive large cohort that you have. So that provides you opportunity to follow longitudinally.
Yes.
Have you done that?
Yes, sir. We are following this. We have our robust record keeping. We have our data both online and offline. So, and we regularly follow up the child. We call them up, or not only for we are doing not only CT angio of this Kawasaki disease patient. We are now started MRI also to see whether we have patients of 25 years, 30 years of patient. They are coming and who were normal initially in echo and CT angio. We are finding endothelial damage in MRI.
So you say that the frequency is increasing. How is the treatment outcome? Has that improved over the years?
Yes, sir. Over the years, basically, if we see initially the treatment was only IVIG, and over the time we know what are the high risk cases, the infants, the higher age of onset, child means cases less than 6 months. So we are giving intensification of primary treatment. initially only IVIG was given, but whenever we are finding high risk cases, we are intensifying the treatment with IVIG and infliximab, and in some cases we are also adding corticosteroids and cyclosporine. Those who have giant aneurysm, and also we are adding low molecular heparin and antiplatelet we are giving in all, and also statin groups of drugs.
Thank you.
One last question. Did you do IgG4 levels in a large vessel vasculitis?
Sir, initially no, but after that, in the last 3 to 4 years, when it is available in our in-house, we are doing IgG4 level. Basically, we are doing not Ig profile and IgG subclass also.
So, what is the correlation between large vessel vasculitis and these
Sir,
levels?
we didn't find any IgG4 related disease so far.
You have not?
No, sir.
Thank you. Thank you all for your patient attendance, and thank you. We close this session.